Hello.
Hi.
Okay. Today I will be examining your heart. So first let me know you or let you introduce yourself. So what's your name?
Vikas Bhattacharya.
Okay. What's your age?
50.
So what do you do or what's your work?
I am a retired army person and now I am doing job.
Okay. So today we'll be performing your heart examination.
Yes.
It's fine with you?
Okay.
Okay. Health history of patient. First of all, while interacting with the patient, observe his or her general appearance. Check for the following key points while interacting with the patient. First, color. Second, respiratory rate. Third is the level of anxiety. Also, try to establish a comforting and supportive relationship with the patient. Anatomy of vessels of neck. The neck is a complex anatomic region between the head and the body. In the front, the neck extends from the bottom part of the mandible, lower jawbone, to the bones of the upper chest and shoulders, including the sternum and collarbones. The back of the neck is mostly comprised of muscles as well as the spine. The major vessels of the neck are external carotid artery, internal jugular vein, and the external jugular vein. These all arteries can be seen in the picture clearly. Before starting any procedure or any physical examination, I would like to keep in mind its safety or like it's sterilized. It should be a sterilized process. So first of all, I would use the hand sanitizer so that no infection or no germs are transmitted from me to the patient for the patient's safety. Jugular venous pressure. The jugular venous pressure JVP reflects pressure in the right atrium or the central venous pressure. The venous pressure is estimated to be the vertical distance between the top of the blood column or the highest point of oscillation and the right atrium. The jugular venous pressure consists of certain waveforms, and any abnormalities of these waveforms can help in diagnosing certain conditions. Steps for measuring the jugular venous pressure. First, make the patient comfortable. Raise the head slightly on the pillow to relax the SCM muscles or the sternocleidomastoid muscles. Second, raise the head of the bed or examining table at around 30 degrees. Turn the patient's head slightly away from the side you are inspecting. Third, examine both sides of the neck. Identify the jugular vein or the external jugular vein on each side. Then find the internal venous pulsations. Fourth, if necessary, raise or lower the head of the bed until you can see the oscillation point or meniscus of the internal jugular venous pulsations in the lower half of the neck. Fifth, focus on the right internal jugular vein. Look for pulsations and also distinguish the pulsations of the internal jugular vein from those of the carotid artery. Sixth, identify the highest point of pulsation in the right jugular vein. Extend a long rectangular object or card horizontally from this point and a centimeter ruler from the sternal angle, making an exact right angle. Measure the vertical distance in centimeters above the sternal angle where the horizontal object crosses the ruler and add to this distance 5 cm, the distance from the sternal angle to the center of the right atrium. The sum is the JVP or the jugular venous pressure. The carotid pulse. While examining the carotid pulse, include the carotid upstroke, its amplitude and contour, and the presence or absence of thrills or bruise. To assess the amplitude and contour, the patient should be supine with the head of the bed to be elevated to about 30 degrees. First, inspect the neck for carotid pulsations, often visible just medial to the sternocleidomastoid muscles. Then place your index finger and middle fingers or left thumb on the right carotid artery in the lower third of the neck and palpate for pulsations. Never palpate both carotid arteries at the same time because this may decrease blood flow to the brain and include syncope. Differences of the jugular venous pressure and the carotid pulse. The below given chart describes or shows various differences found between the jugular venous pressure and the carotid pulse. These both are majorly found while inspecting or palpating the patient. Anatomy of heart. The heart is made up of four chambers. Two upper chambers known as the left atrium and right atrium, and two lower chambers called the right and left ventricles. It is also made up of four valves: the tricuspid valve, the pulmonary valve, the mitral valve, and the aortic valves. This picture also depicts here the direction of the flow of the blood. Inspection of the heart. First of all, while inspecting the anterior chest, find the location of the apical impulse or the PMI or the point of maximal impulse. Shine light across the chest wall over the cardiac apex to make these movements more visible. Palpation of the heart. Palpation of the precordium can be useful. Locate the apex beat, the furthest point laterally and inferiorly where you can clearly feel the apex, usually the fifth intercostal space in the mid clavicular line. There are many different descriptions for abnormal apex beats. One scheme distinguishes having high afterload, example aortic stenosis, from thrusting, that is high preload, example aortic regurgitation. The apex may also be tapping, but this reflects a loud first heart sound. In addition, you should place your left hand over the sternum and feel for any significant ventricular heave or right ventricular hypertrophy or thrill, that is tight aortic stenosis or ventricular septal defects. Breathe in and hold. Exhale to release. Good enough. Auscultation of heart. Listen over the aortic, which is found in the second right intercostal space, and pulmonary, second left intercostal space areas, and at the left lower sternal edge with the diaphragm of your stethoscope, which is better for higher pitches. Then use the bell for the apex, which is better for lower pitches. Press lightly with the bell. If you hear an abnormality over the aortic or pulmonary areas, you should listen over the carotids. If you hear an abnormality at the apex, listen in the axilla. Listen systematically. Start with the heart sounds. Now I would be using a stethoscope to hear the sounds or the heart sounds more properly. Okay?
Yes.
Heart sounds. First heart sound, which is the S1. The first heart sound results from the closing of the mitral and tricuspid valves. The sound produced by the closure of the mitral valve is termed M1, and the sound produced by closure of the tricuspid valve is termed T1. The M1 sound is much louder than the T1 sound due to the high pressures in the left side of the heart. Second heart sound, or the S2. The second heart sound is produced by the closure of the aortic and pulmonic valves. The sound produced by the closure of the aortic valve is termed A2, and the sound produced by the closure of the pulmonic valve is termed P2. Third heart sound, which is S3. The third heart sound, also known as the ventricular gallop, occurs just after S2 when the mitral valve opens, allowing passive filling of the left ventricle. The S3 sound is actually produced by the large amount of blood striking a very compliant left ventricle. Fourth heart sound, or the S4. The fourth heart sound, also known as the atrial gallop, occurs just before S1 when the atria contract to force blood into the left ventricle. If the left ventricle is non-compliant and atrial contraction forces blood through the atrioventricular valves, a S4 is produced by the blood striking the left ventricle. Performing maneuvers. For cardiac examination, two important and useful maneuvers are performed, one to enhance detection of the mitral stenosis and another for the aortic regurgitation. First, maneuver for mitral stenosis. Ask the patient to roll into the left lateral decubitus position, which brings the left ventricle closer to the chest wall. Place the bell of your stethoscope lightly on the lateral impulses and hear the sound. Now you can please turn to the lateral side. Okay. Second, maneuver for aortic regurgitation. Ask the patient to sit up, lean forward, exhale completely, and briefly stop breathing after expiration. Pressing the diaphragm of your stethoscope on the chest. Listen along the left sternal border and the apex, pausing periodically so the patient may breathe. You just sit straight. You lean forward a little bit. Now what you have to do is you have to inspire air, then expire it completely and just hold the breath at that moment.
Okay.
Okay? Okay. Inspire air, expire it, and just hold it. Okay. Relax. Relax. Heart murmurs. After inspecting the heart sound and its variations, move on to consider the gaps between the heart sounds. If you hear a murmur, first establish whether it occurs in systole or diastole. Time against the carotid pulse if necessary. Then determine its length and if short, its exact position. Early, mid, or late systole or diastole. Now, the various types of murmurs in the systolic and the diastolic phases are presented in the chart shown here. My findings for today's cardiac examination are: jugular venous pressure is 2 cm above the sternal angle with head of bed elevated to 30 degrees or 7 cm above the right atrium. Carotid upstrokes are brisk without any bruise. Also, while auscultating the heartbeats, there were no extra or additional heart sounds found. The presence of murmurs are also not found while the examination. Thank you.